Hey everyone, this is Dr. Rapoff. We're going to talk about sepsis today, a true time-critical diagnosis. Sepsis affects about 1.7 million Americans on an annual basis, and this is in comparison to about 800,000 heart attacks and about 750,000 strokes. So it's over double both of those disease entities. About 350,000 people die annually in the United States, and it's our number one cause of in-hospital mortality. The black line represents the percent survivability, and the purple bars represent time to antibiotics. The typical time to antibiotics in-house for hospitals is around 2 to 4 hour mark. What we're shooting to do with the pre-hospital antibiotics is to be somewhere around the 0 and really minus 20, minus 30 minutes to patient's arrival. Every hour there's a 7% increase in mortality in delay of antibiotics that's given. This one intervention you will do will save more lives than most everything else we do combined. In terms of identifying sepsis, you've got about 11% of the time when people have a fever, they're truly septic. Now, when you take into account patients that we transport, these are typically our elderly, our immune compromised, our sicker patients, and it's probably closer to 30-50% of the time, have a very high index of suspicion when somebody has a fever. There's a number of other signs we need to look for: hypotension, altered mental status, tachypnea greater than 22, a heart rate that's greater than 90, if they're hypoxic on room air or their normal oxygenation. Of course, if they have a fever, but also if they're hypothermic as well, can be a sign of sepsis, and delayed cap refill. Amongst the other things we need to worry about, age is a major risk factor, previous surgeries, immune compromised, if they're bedridden, if they've got indwelling devices, as well as elevated blood sugars are things to watch out for. So here's the protocols. Here's what we're going with. It's the H.A.T protocols. This is a protocol that's already being used in multiple places of the country. This is a very sensitive, very specific. So it starts at the top here. We've got sepsis, signs of infection, signs of fever, plus 2 of the following criteria. We've got hypotension, we've got altered mental status, and we've got tachypnea. When you go down this pathway, ideally, we're going to draw blood cultures times 2, administer antibiotics. We're going to use Rocephin or Maxipine, IV or IM administration. And then if the patient is hypotensive, we go down this left side and we'll start IV fluids. And if persistently hypotensive, we can start down the pressors. The only thing that has shown to decrease morbidity, mortality, and sepsis is not identification. It's not fluids. It's not blood cultures. It starts and finishes with antibiotics. So why did we pick Rocephin? It's a good broad spectrum antibiotic. It has a 3rd generation cephalosporin. It's got good coverage against gram-positive, gram-negative bugs. Essentially, it will cover most of the things we're worried about. It's room stable. You don't have to refrigerate it. It kind of stays with the rest of the medications that we have. Its shelf life is good. It's up to 2 years, but I can assure you once we really get these protocols running, you won't have it on your shelf for more than a month or 2. You can be given IV or intramuscular, which is nice about the medication itself. The cost is relatively efficient. It's somewhere between $2 to $3 range. It's a very well-tolerated medication unless you've got somebody that has a specific cephalosporin allergy. People do pretty well with it. It has a low side effect profile. It's in a relatively abundant supply, and the risks of giving are pretty low and the rewards are very high, especially in relation to a lot of the things we do in pre-hospital EMS medicine. So how does this look when we get to the patients? Show up to their house. We start an IV line. We draw the first set of blood cultures, and this is blood cultures if the receiving hospital is requesting blood cultures. Prep the antibiotics. Some preparations are powder, some are liquid, so it may take a few minutes to get them ready. We draw the second set of blood cultures from a different site. It's usually about 5 minutes after the first set was drawn. Then we give the antibiotics. Do not delay antibiotics if you're unable to obtain an IV line or blood cultures. This happens often in the emergency department. Blood cultures, IV lines, fluid boluses, none of it affects morbidity, mortality. Give the IV antibiotic or IM antibiotic if you have it prepared. And then start the fluid bolus. Have that running as you decide to call a code sepsis and then eventually transport. So again, this is a time-critical diagnosis. Early antibiotics is the only thing that really affects how patients do in this whole process, and we're going to save a lot of lives. Thanks, y'all.